Okay, so good afternoon, all. Shweta, can you please just once confirm if if I'm audible enough?
You're audible.
Great. Thank you all, and I hope everybody's keeping safe as well. It's a very tough time for all of us. I mean, all of us from the medical side, we know how and how busy times we're going through. So I'll be a little, I convey my apology in advance in case if sometimes if because of any urgency, if I get a call, I'll have to take the call. But I'll try to make sure not to disturb. So welcome again for the week 4 of the topic. Last week, we all have gone through the non-CNS and the non-TB components. It is going to be a very vast topic, but I'll try to do the justice because in the given time, I'm not sure we'll be able to cover everything. But the overall idea of the presentation is that we touch upon the basic concepts and think about from the approach side, like what are we going to do in case if we come across these kind of cases, and how do we proceed further? Because going into the details of each and every case management wouldn't be possible, and that's not the intent of the presentation. So let's start with, so we have got 2 topics. We have got neurological manifestations today, and also then we'll go into the HIV TB components. Next slide, please. Next, please. Okay, so starting with the involvement in the nervous system, we know that the HIV invades fairly early during the course of infection, and it progresses with the advancement of the infection in the host. And also what we know is like it has got the capacity to affect almost all part of the neural axis. That's something which we know. And then a lot of studies have already shown that the neurological system involvement is actually the first of some of the symptoms or the manifestations of HIV that we get in around 10 to 20% of infected persons. So it's not a huge in terms of presentation, but then it's quite complex when it presents. So we'll see in subsequent slides how the case present. And also the lifetime prevalence of clinically evident neurological problems is around 60%. And also in the autopsy studies, it was seen that the pathological abnormalities that we saw mostly, almost in all cases, if you see 75 to 90% of the cases, and more in advanced cases. Next slide, please. In this slide, what I wanted to show is, let's look at the neurological manifestation of infection. So when we say there are 2 things, we all know what is opportunistic infection for sure. And then HIV per se, HIV virus itself also leads to a lot of problems, not just the opportunistic infection that you get as a neurological manifestation, but HIV per se. So when you see on the right side, you have all the OIs listed. So you have cryptococcal meningitis, toxoplasmosis, CMV retinitis, PML, lymphoma, tuberculosis, syphilis, etc. Tuberculosis being a co-infection and OI both at the same time. And also, if you see the HIV per se infection, that HIV itself can cause aseptic meningitis. HIV can cause HIV encephalopathy, which is known as AIDS, dementia. We'll also talk about that. So different kind of myelopathy, neuropathy, changes which HIV per se can also do. So that's something we need to keep in mind, because so there are 3 things for a person to know. One is like, what is co-infection, what is opportunistic infection, and also what is HIV related or associated illnesses. So that's something just to keep in mind. Next slide, please. Now, So if you see the neurological syndromes that we are seeing here, again, for this purpose only, I've categorized it in a way that you always approach from these angle of syndromes. So the patients, how do they present? Because most of us working in the ERT centers, we see that the patients always present with the set of symptoms, right? So what kind of a differential diagnosis that comes into your mind when somebody is presenting with those set of signs and symptoms? So looking at meningitis, as we know that the typical meningitis or the meningismus symptoms, what we know is the patient can present with headache, fever with nausea, vomiting, and altered consciousness. And what are the differential diagnoses that comes to your mind? Tuberculosis, cryptococcosis, syphilis, and other bacterial infections. Again, bacterial meningitis would be more in terms of co-infection, but it can also occur in PLHIVs, we know that. Now, when we talk about the focal cerebral lesions, typically patients presented with headache, focal neurological signs and convulsions. And in these, we have to think about tuberculoma, toxoplasmosis, progressive multifocal leukoencephalopathy, syphilis, primary CNS lymphoma, and non-neurocysticercosis. Then encephalitis, if somebody you presenting with a syndrome of cognitive impairment, psychiatric features and altered consciousness, may not be presenting with fever all the time. Then you have cytomegalovirus in mind, herpes simplex, and or toxoplasmosis. Then patients presenting with sensory disturbances, paraparesis, or sphincter disturbances. So this I kept in for a purpose because one has to think about myelitis, and definitely the etiology which should come into your mind is cytomegalovirus, herpes simplex, syphilis, toxoplasmosis, and tuberculosis. All these can lead to myelitis. Then the neurocognitive decline, which is also entity which is known as HIV-associated neurocognitive dysfunction, or HAND. HIV-associated dementia, which you all must have heard of, that's actually a part of HAND, other than, and then on top of that, there are some other neuropathies included. And generally, the patient presents with memory loss, behavioral abnormalities, and motor function deterioration. So please keep in mind when somebody is presenting with these set of signs and syndromes, and then what are the differential diagnoses that should come into your mind. Next slide, please. Look at this. So this is something which is, these coming two slides I've kept it. These are not as such there in the guidelines as of now, but for us to think about, or from the medical officer angle, or from somebody who's the first responder to the patient. So we look at and see what we have done is, like, you generally try to ask and assess and then examine and refer or manage. So in terms of the similar lines of what happens in IMCI. So you look for any of the neurological symptoms which can fit into. So for example, you have meningismus, where headache, photophobia, and neck stiffness is usually going to be the presentation. And then you've got focal neurological issues, where you can look for the cranial nerve problems, visual problems, hemiplegia, paraplegia, abnormal movements, or ataxia. Then altered mental status, you look for confusion, reduced consciousness, strange behavior, or headache. So there was a reason for us to think in this direction. So let's look at the three yellow boxes that are there. So when you look at the symptoms of meningitis, somebody presenting with fever, headache, malaise, confusion, stiff neck, photophobia, or vomiting, you have to think about, we are talking about all the possible causes of meningitis here. And then definitely one has to see the acuteness of symptoms. You have to see, is there any other symptom outside CNS? You have to look at your CD4 counts and viral load, and you ask for the adherence, and also the review. I mean, CD4 count, again, review that to identify the paradoxical iris in terms of the relation of symptoms. And then you need to examine, you have to look at the level of consciousness, you have to look at neck stiffness, you have to look for specific cranial nerves, things that you need to check for focal neurological deficits, and assess the tone and reflexes if the patient is unconscious. And then you have got the second box, which is talking about if the patient is presenting to you with floaters or partial loss of vision, peripheral visual field defects, etc. So this is something which probably should come to your mind when you have to think about. So we are talking about here cytomegalovirus or ocular tuberculosis. Ocular tuberculosis is quite rare, but it's still cytomegalovirus is something which it's actually a hidden disease for a lot of Indian PLHIV because we don't have fundoscopy, we don't have routine fundoscopy to be done as a screening. So that's something which is which you should keep in mind. And then on the third side, third box you see, we're talking about headache with seizures, focal neurological signs, with cranial problems, hemiplegia, paraplegia, abnormal movements, and altered mental status. So again, in this, we are mostly going towards in direction of any of the occupying lesions or toxoplasmosis or anything else, which would also include hand here by default. So when we look at these, the reason why I'm stressing upon in these initial few slides, you'll all go through the details of all the OIs in your textbooks, etc. But at least for the approach that we should know that this is how we have to focus and follow. Next slide, please. Then just to elaborate on the meningitis here. So one has to see, for example, I mean, you have to make sure that the patient goes for CSF analysis. You have to make sure that the patient would be tested for VDRL. You refer for imaging in case if you have to rule out the other causes at the same time, and also make sure that so this one point that what I've written here is for any kind of a meningitis symptomatic cases, you have to also should perform the serum crack test. We'll come back to this test later on. Right now, this test is not available in India, but I think because this is a theoretical class, we can talk about it. So serum crack antigen, something which picks the, so we're talking about the cryptococcal antigen. So what happens is the advantage of this cryptococcal antigen is that it can present even before the patient starts showing symptoms. So it is quite interesting because you can pick the cases quite early. And also we'll talk about more in the cryptococcal meningitis topic about this. And so when you have a serum crack positive, then you have to then further confirm it with the CSF crack antigen, and then accordingly you manage the case. And we'll come to that as well. But then one thing to keep in mind is you have to make sure that there is a good number of tests that you have to do to rule out everything. Next, please. So till now, what we talked about is we talked about the syndrome. So you have a cluster of symptoms, and right now, and there is also a possibility that the patient can simply present with fever or just the headache. So the patient is presenting with headache and is persistent and severe. Then also we also need to look for previous history, look for thrush, weight loss, and also look for CD4 counts. And then what we discussed in the previous slide as well, again, the division is you look for fever plus minus signs of meningismus. If that's there, then you're targeting for the CSF analysis, and the other tests that I talked about should also be done. At the same time, if you have the meningismus signs are not there, and then focal seizures are there or signs along with the headache, then you know that probably you go for the imaging techniques. And then again there, if you get the ring enhancing lesions, that you know that you're probably talking about toxoplasmosis. And that's where you treat for it and then further go on. So we'll come to more details of each and every OI in the subsequent slides. Now, next slide, please. Now look at the case here. So we have a 32-year-old male with CD4 count of 49, presenting with headache, fever, and fatigue of subacute onset. He was treated symptomatically with paracetamol and antibiotics. He returns a few days later with lethargy, fever, and again temperature, worsening headache, and a molluscum-like skin lesions. And then examination revealed no systematic signs, and nervous system also didn't reveal any focal lesions. Next, please. So I would like all of us to look at the lesions, and so if you describe, so I would have loved to go into the details of each and every case study, but I think just for time management, so I would be just reading it out and making sure that you all have seen it. So what we see is you can see that there are multiple white papules over the face, and so what other questions that you would like to have? I mean, you would like to ask in the history or in the physical examination, you like to also further go ahead and you like to do the symptom analysis for fever, with what kind of a fever it is, what are the associated other things like chills, sweating, or vomiting, how is the headache, is the headache very severe, is it associated with the projectile vomiting that you must check, what are the other symptoms involved? So you look for pulmonary symptoms as well, look for the family history of TB. Then TB exposure is important for us to know in this. Then for physical examination, then you look for the distribution of molluscum-like lesion, because that's important for us to rule out from molluscum contagiosum or the cryptococcal typical molluscum looking like lesions that usually you see. Then other history, relevant history that what we usually take. Then so one thing is, once you have this kind of a case, then you will like to know what kind of a diagnostic test that you would like to perform. So one would go for CSF analysis in this for sure. You need to look for cells, protein, sugar. You look for opening pressure for sure, because patients with meningitis, typically in this case, you would like to also know the opening pressure of CSF. You would like to definitely go for CD4 cell counts and a PCR test. I mean, if that's available or possible for some of the viral diseases that you want to rule out, for example, HSV or CMV. Then CT or MRI with contrast if necessary, as we discussed. Next, please. So any neurological condition for that matter, I mean, that you come across, you always make sure that you need to see, first of all, where is the focus? Is there a neurological lesion? Where is the lesion? According to the symptoms, you try to rule out that, and what is the lesion? That's something that these are the basic questions that you should have in your mind. Next, please. So does this patient have meningitis? That's the basic question that you have to kind of think about it in your mind. So you look at the opening pressure that we are talking about. So yes, there is very high pressure, protein is raised, cell counts raised. So what's the differential diagnosis that you're talking about? So any patient that you come across like this with the fever, with headache, and if there are no focal neurological problems or the systematic findings, you always have to think about the infective etiologies. I mean, you need to think about tuberculosis, meningitis, or there are several bacterial meningitis causes like Streptococcus pneumonia, H. influenza, Neisseria meningitidis. And definitely the meningitis with cryptococcal meningitis or histo is quite rare, but then still cryptococcal meningitis is something which would always should be in your mind, along with other viruses causing meningoencephalitis, for example, HSV or syphilitic meningitis. Meningomyelitis is quite rare, but then still to keep in mind. So some of the viral causes that also you need to keep in mind. Next, please. So this is exactly what I was talking about. So in this particular scenario, you would like to think about all the different causes of meningitis, which I have just listed out already. So let's see, during the CSF examination per se, what are the different pictures or the different scenarios that you can have as a snapshot. We'll see in the next slide. Next slide, please. So in a case where you're suspecting cryptococcal meningitis, it's mostly lymphocytic and then sometimes the cells might be normal. You will get you'll have elevated proteins and low sugar. Microbiology is still in a lot of medical colleges, almost in all medical colleges, we still do India ink preparation. It's not very sensitive, but still that's the best that we have at the moment. And the antigen test that I talked about, probably because it's not available everywhere, some of the medical colleges are doing it, but it's not there as such from the NACO side as the guidance. So at the moment, just for the information, at the NACO level, we are working on the advanced disease management package, wherein we are trying to include that serum antigen as a screening package to start with. But this is just for the information, unless until it comes down to the centers officially from NACO, we don't do it. Then look at the tuberculosis component. It's also lymphocytic. There are going to be a few hundred lymphocytes, elevated proteins, low or normal sugar. And then we know the diagnosis that we have to make microbiologically for tuberculosis. If it is pneumococcus, it's mostly going to be neutrophilic, more than 1,000 cells you might see. Protein is going to be very high and very low sugar. That's a typical of pneumococcus or of the bacterial meningitis. And then gram stain, the routine culture that you have to do. For syphilitic meningitis, it's again lymphocytic, cells are mildly elevated, the protein is a little high, sugar near normal, and then you can always do the VDRL test for that. Next slide, please. So what we just talked about, CSF India ink preparation in case of, so what you see here is the cryptococcal capsule, which you see, and there's a clear halo around the capsule, which is because the capsule doesn't take the ink. So, there's a background of India ink and then capsule doesn't take it. So that's how you get the halo around. It's a very peculiar and typical picture. If one sees, then for sure that you cannot miss cryptococcal meningitis. So it's a CSF sample. Next, please. So to talk about cryptococcal meningitis, it's caused by the encapsulated yeast of Cryptococcus neoformans or GATI. Neoformans it's most common in immunocompromised patients. And also it's also for some people has been referring this as a sleeping disease in low middle income countries, because the diagnosis is quite difficult and it's not widely available everywhere. So, and also it accounts for almost like 15% of all AIDS related deaths. So you can imagine huge burden we are seeing. And just to talk about the third point here, sorry for the cluttering, but then, so what we see in short is that the people with CD4 count of less than 100, the pooled prevalence of cryptococcal antigen was almost 6.4%, and 2% among people those who were having CD4 of 100 to 200. So in total, if you see, we're talking about almost 8% of cryptococcal antigenemia. What does this mean? I mean, because we're not doing any screening, so you can imagine we are missing a lot of cases. As I told you in the starting, that cryptococcal antigen can also remain it can remain positive even after the treatment. That's a different story. But then for the screening test, it's a quite wonderful test, because you can pick the test even before the patient starts showing symptoms. So here, a lot of asymptomatic cryptococcemia cases probably you would also be able to pick if one do the cryptococcal antigen testing. So that's the whole idea behind putting that into the screening package. It is recommended by WHO and approved by TRG, and hopefully it would be scaled up everywhere. The major reasons, as I told you, high mortality is delay in diagnosis, and also because you have to also depend on the lumbar puncture for getting it confirmed. Next, please. The primary manifestation, cryptococcal meningitis, it presents as subacute meningitis or meningoencephalitis. Most patients with early cryptococcal meningitis, they develop non-specific symptoms, fever, headache, and approximately 60 to 75% do not have classic signs of meningeal irritation. That's why it is important to keep it as a syndrome and then screen the disease. As the disease progresses, you can have neck stiffness or cranial nerve abnormalities. Also, as we saw in the case also before, skin lesions are also possible, and those are typical umbilicated lesions. You can have those can very well mimic molluscum contagiosum. And it can have isolated pulmonary infection as well. So you can have pulmonary cryptococcosis, but then that's quite rare. Next, please. Okay, so I have briefly touched upon this serum cryptococcal antigen, but then I think for the information, it is very important because it's there in the guidelines, but it's not yet in the practice. So when you're there and then you see any of the danger signs, which is you have temperature of more than 39 or respiratory rate more than 30, heart rate more than 120, or unable to walk unaided and altered sensoriums. If any of the danger signs are there, then so the typical approach for a patient should be that you have the danger signs, you go for expert management. Otherwise, you look for the symptoms of meningitis, as I showed before in the syndromic approach as well. If these symptoms are there, then you go for serum CRAG testing. Once you do the serum CRAG testing, then if serum CRAG is positive, then what you need to do is then you need to confirm it by the CSF CRAG testing. If the CSF CRAG is positive, then you can start the treatment for cryptococcal meningitis. If the CSF CRAG is negative, then in that case, or if there is any contraindication, you do not do LP, or you cannot do LP, and then because serum CRAG is positive and CSF is not positive, that's where you actually do the starting of preemptive therapy. So this preemptive therapy is something which is also recommended. We usually give fluconazole in this. If you remember what I just mentioned before, there is usually when you have the CNS involvement, we're already there in the disseminated phase. You have the pulmonary involvement, you have other systems involvement. That's the reason you get the serum CRAG positivity. But then if CSF is not there, it's a good practice to start on preemptive therapy, which is fluconazole. And then if both are positive or CSF is positive, then definitely you need to start the treatment for cryptococcal meningitis. Keep in mind that this is all going to come to all of us very soon. But for the theory, we should know, because a lot of countries, and also it is because it is WHO recommended, TRG recommended. So that's the reason I'm talking about it. But do not start everything on your own at the DRT center, because you do not have serum CRAG kits available with you at the moment. I'm not sure. Next, please. So when we talk about the management of cryptococcal meningitis, we just said, so there are going to be, so there are three approaches. One is the preferred one, which is there. You can see you're talking about amphotericin B deoxycholate and flucytosine for a week. Then fluconazole. So one thing is, sorry, I'll come back to this again. So you give amphotericin B deoxycholate and flucytosine for 1 week, and fluconazole for 1 week. So there's 2 weeks of treatment, which is the preferred regimen. The alternative approaches are, you can give 2 weeks of fluconazole and flucytosine, or 2 weeks of amphotericin B and fluconazole. All are effective in a way, but then what happens is you see that toxicity because of amphotericin B deoxycholate would be higher in some cases, and also when the country has to take a decision, it's also the cost included. So the preferred regimen as of now is the first one which you see, and then you have the consolidation phase where you give fluconazole for 8 weeks, and then continues the maintenance phase. Next, please. In the maintenance phase, you have fluconazole again to be given. It's also known as secondary prophylaxis. It is recommended that you continue, because a lot of relapses cases have been noticed if you do not continue on secondary prophylaxis, and that's something which we have to keep in mind because it's a long-term treatment. There's going to be a lot of challenge to continue this, but once it starts, we'll see how to do that. And how do you discontinue fluconazole maintenance therapy? The patient is stable on the ART and adherent on the ART, and you have given at least for 1 year, or CD4 count of more than 100, or there is suppressed viral load. This is something which is challenging, but this is to make sure that we do not get the relapse. Next, please. Okay, so let's move to different entity. Okay, so we have a case study now, which is a 32-year-old HIV positive male presenting with focal convulsions. On systematic examinations, you see that right upper limb weakness is there, monoparesis with no other abnormalities. Next, please. So the case is presenting with the typical findings which you can see in the contrast CT. You can see there are multiple ring enhancing lesions involving both the hemispheres, and there is also surrounding edema, and there's no shift of the midline. Next, please. So the case, somebody presenting with this, that when we're talking about the focal neurological deficit and the ring enhancing lesions, what are the differential diagnoses that we're talking about? We're talking about toxoplasmosis, tuberculoma, neurocystic fibrosis, brain abscess, and primary lymphoma. Now, there can be other rare causes as well. Some of the metastasis of glioma, some of the different other fungi can also present like that, but then those are not much seen in our settings. So these are our typical differential diagnosis, which should be there in our mind. The next slide, please. So what are the features of toxoplasmosis that we know? A typical patients typically presents with subacute presentation. So that's something that you have to keep in mind. And then you can have varied symptoms. You can have starting with headache, fever, or the behavioral changes also can be there. You can have confusion, lethargy, and can have hemiparesis or seizures. Sometimes there are also cases where you see cranial nerve involvement as well. So that's a presentation for toxoplasmosis. Next slide, please. You can see in typical for diagnosis of toxoplasmosis, we are mainly relying on the three things: imaging techniques, serology, and then and also because what happens is you usually see the response to the therapy, because there's nothing definite we have other than brain biopsy as such. So typically the lesions associated with the toxoplasmosis, they begin as a focus of encephalitis and progresses to abscess, or can also develop necrosis and inflammation. Usually are located, lesions are usually unifocal or multifocal, but then it can vary in size from microscopic to quite large. We've seen cases like that. And then lesions are mostly located in the parietal or the frontal lobes, sometimes at the cortico-medullary junction or the basal ganglia as well. So depending on where the lesion is, as we know, we'll have the presentations accordingly. Serology for IgG is positive in almost 95% of patients. So that's something which we do. And then definitely presumptive diagnosis is usually when you have a characteristic presentation and then you see the response to anti-toxoplasma therapy. That's something which is, you can say, even we do it on routine basis, because we do not have always the approach for definitive diagnosis, which is brain biopsy. Next slide, please. You see many ring enhancing lesions you can see in this. Next, please. Acute treatment. Okay, let's quickly, but anyway, you all will be having the slides and the material, so I'm not going into the details of each and every drugs, dosage, etc. So you have the sulfadiazine and plus pyrimethamine, which should be given for 6 weeks. Alternatively, you can have clindamycin or pyrimethamine. Next best option for us is high dose cotrimoxazole, which is sometimes the only thing which we are left with. So just to keep in mind. Next, please. Maintenance therapy is again pyrimethamine plus sulfadiazine. And all patients require prolonged suppressive therapy following cure. This may be withdrawn only after improvement with ART and CD4 raising more than 200 and sustained for at least 6 months. Follow-up is very important for toxo cases because the clinical improvement, as I said, that we have to see the improvement, and 86% of the patients in several studies we've seen that clinical improvement by day 7 of treatment is seen, and also 95% patients show radiographic improvement by day 14. So that's something which is also for us to see whether our treatment is working or not. In case if that's not working, then we know that probably we'll have to think about something else, for example, tuberculoma or PML, etc. Next, please. So the next entity that we have right now is tuberculoma and TB abscess. So the tuberculoma are solitary or multiple lesions, smaller than 1 centimeter in size, with nodular or ring enhancement, and without associated mass effectority. In contrast, the abscess is large, solitary lesion with central area of liquefaction. And in MRI, they appear hyperintense and are generally associated with mass effects and ring enhancement. So that's something which we have to differentiate. And hydrocephalus basilar meningitis or cerebellar infarction develops in at least 1/3 of patients with CNS tuberculosis. Next, please. Okay, so now we are going to a different entity. So just to think in that direction, that you have a 40-year-old female with CD4 of 44, not an ART, presenting with incoordination of her right hand, unsteady gait, and slurred speech. This woman was alert and well-oriented. You can see the vitals here, and she has a slight right facial droop, right hand weakness and dysmetria, unsteady gait due to mild right leg weakness. The next, please. So this patient, if you see in the MRI, the contrast MRIs, they show multiple areas of high signal intensity, and they're mostly localized to the subcortical white matter. And then you see there's no mass effect. So the probable diagnosis in this kind of a picture, we're talking about PML, progressive multifocal leukoencephalopathy. Next, please. So let's talk about PML a bit. So PML is a rare demyelinating disease, almost exclusively seen in immunocompromised patients. It is caused by polyoma virus, JC virus, also as known, JC John Cunningham, given by the person from whom it was cultured for the first time. So the PML is caused by reactivation of a common virus in this CNS of immunocompromised individuals. This virus is carried by majority of people and is harmless except among those who have poor immune defense system. So that typically presents with focal CNS signs, and also can have cognitive dysfunction, ataxia, aphasia, nerve deficits, paresis, typically depending on what part of the lobe is involved. So if you see, it also has got a preference for occipital lobes, where the patient would present as hemianopia. Then you have the frontal and parietal lobes, where the patient can have hemiparesis or involvement of cerebellum, where you can have ataxia or dysmetria. Seizures are also noticed and seen in 20% of the cases. Next, please. And The CT typically include or provide non-enhancing or poorly enhancing white matter lesions. So that's something which it's important for us to keep in mind. And MRI findings are patchy white matter lesions, and very sometimes 10 to 15% of cases can see a bit of enhancement with gadolinium. Next, please. For the lab diagnosis, the JCV DNA, which can be detected by PCR from the CSF specimens, sensitivity, it's a big range, but then mean is still quite impressive, 80% of sensitivity and specificity of 95%. So the lab diagnosis is quite important and informative. And because of the high positive predictive value of the test, the patient with a positive PCR result who has a compatible radiological picture can be assumed to have PML. So that's something which is important for us to remember. And however, a negative test result does not rule out PML. Next, please. Then for treatment, we actually do not have any specific treatment as of now, but ART per se is the treatment for PML, and more than 60% of the response rate has been seen, and with not that much of improvement, but 20 to 30% of improvement has been noted in various studies. Definitely the poor outcome is with people, those who are having CD4 less than 150, or you can say advanced disease. Steroids typically have got a role, and also as we have already discussed in the previous sessions as well, that steroids have a role for PML iris. Next, please. So now we are jumping into the another entity, and let's look at the case where you have a 34-year-old male who is presenting with CD4 of 146, presenting with involuntary movements affecting all limbs, and weakness of all 4 limbs, difficulty in walking, loss of memory, and slurring of speech. According to his wife, all the problems evolved over the period of 3 months. He was disoriented, and the mini mental test score was 18. Okay, next slide, please. So the slide of, you see the MRI of this patient, it's showing cortical atrophy and also showing enlargement of ventricles. So what we're talking about here is hand that I mentioned before, or as widely known as AIDS-related dementia or AIDS dementia. Typically, AIDS dementia usually presents in patients with CD4 of less than 200, or the advanced cases. It's a slowly progressive disease, presents with persistent or acquired cognitive decline, can have the motor involvement or the behavioral changes as well. Typically, the neurological examination, the patient is alert with non-focal or diffuse signs. CSF examination is usually non-specific, and in CT or MRI, which you typically get, what is shown here is the cerebral atrophy and the ventricular dilatation. And the therapy or the treatment, what we have in hand is ARTs. Next slide, please. So usually, typically, the AIDS-related dementia presents with a triad of cognitive, motor, or behavioral dysfunction. It evolves over weeks to months. Typically, the early symptoms which you see is apathy, memory loss, or cognitive slowing. Patient can have symptoms later as global loss of cognition or the psychomotor retardation. It can be diagnosed through physical examination, and thorough physical examination is important. And also you have to think about the dementia scale. I am not probably sure that how much detail we can go here for the HIV dementia scale, but I would like you all to read it. So the AIDS dementia scale is where you look for the psychomotor speed. There are tests for memory recall. There are some tests for reconstruction. You ask the patient to copy a cube or a square and then record time and what's happening. So there is a typical dementia scale that is required to see, and if somebody presenting with a lesser risk score, that the patient is suffering from this. Next slide, please. As we talked about, there is no specific treatment that we have of AIDS dementia, and ERT has been showing the effect, and it has decreased the frequency of AIDS dementia over the period of time. We also have seen the decreased reporting. Because the CNS penetration of ARVs is really important to give that much of effect and make sure that the dementia is prevented. Next slide, please. Now we are talking about some of the topics that, if you remember, when I started, I talked about the HIV-associated illnesses or HIV per se, what the virus can do. So what we have is something called Vacuolar Myelopathy, which typically presents with weakness and spasticity of hip, knee, and ankle flexors. You can have bowel and bladder incontinence, and then if the sensory neuropathy is present, you typically have the distal sensory loss or the reduced or absent jerks. Pathology is typically what the virus does is it causes vacuolization of the myelin sheath and leads to accumulation of macrophages and microglia with relative sparing of exomes. So that typically shows how the patient is going to present with. Next slide, please. And somebody with those presentations, that the differential diagnosis that you have to keep in mind, you think about B12 deficiency, compressive myelopathy, or HTLV, Warco infection. Make sure that you do CSF analysis as well, CD4 count, and then if required, thoracic spinal imaging, which usually comes out to be normal in these cases. Typical treatment we have is physiotherapy and ART. Next slide, please. Then again, neuropathies one can have. HIV per se can lead to neuropathies. There are 4 things that you can see, plus, so please don't get, there are so many details that we have in this presentation, but then what you have to also focus is, you please see the first, which is distal symmetric polyneuropathy, which is the most common form of neuropathy that you get, but it's still, it's good to remember the other, which is mononeuropathy, multiplex, chronic inflammatory demyelinating polyneuropathy, and the progressive lumbosacral polyneuropathy. But what is most common is the first one, which is distal symmetric polyneuropathy. Next, please. So as I mentioned, the distal one is the most prominent or the most common type, and usually the patient presents with tingling, numbness, and burning pain in the feet, and it's ascending over time. Keep in mind this. And then on examination, you get the bilateral depressed ankle reflexes, you get loss of vibration sense and decreased appreciation of temperature receptor. And also you get the mild motor weakness in these cases. Next slide, please. Then you also get neuromuscular weakness syndrome. Typical clinical findings could be ascending paralysis or areflexia, with or without cranial nerve or sensory involvement. Typical investigations, you get lectin and CPK raised, which you get in any neuromuscular weakness. And then the treatment supportive is riboflavin, and introduce alternate and RTIs after lactate level is normal for 3 months. So this was the previous good practice. Next slide, please. So now we are entering into ocular evaluation. So mostly we are going to talk about the CMV here. We are not going to talk about ocular TB, which is something which is very rare for us to see in the common practice. So ocular manifestations occur in 50 to 75% of its patients, often before appearance of other system-like features. So you have torchlight examination or flashlight examination. But what is important is you have to look for or you have to do the evaluation for the fundus. You have to look for papilledema, you have to look for examination of eye, otherwise is also important because you have to look for the ocular motility, etc. But definitely you have to look for fundus. And dilatation of pupil is not dangerous unless the patient is at the risk of glaucoma. This should be done. And then as you see at the last point, which you're seeing here, fundus examination in PLHIV with CD4 count of less than 100. It's important to rule out CMV retinitis. Now, CMV retinitis, if I say it's an end organ disease in advanced immunosuppression cases, but also retinitis is the most common clinical manifestation of CMV cytomegalovirus, and typically you get the peripheral retinitis picture in CMV cases where the patients presenting with floaters, scotomata, or what you call is as peripheral field defects. And so it's very important to look for visual acuity as well, typically with any all the advanced cases for sure. And other than the retinitis, as we all know, that the CMV can also affect lung. It's rare, but you can have pneumonitis, you can have colitis around. I would say less than 10% patients of CMV also present with colitis. And you can have CMV neurological disease as well, which we talked briefly before. Yeah, next slide, please. So what you see here is the typical lesions which you see in fundoscopy of CMV retinitis. Treatment, it's quite it's a quite expensive one also and then sometimes it's not even the drugs availability is a major problem in most of the places. But for the induction for CMV retinitis, you give IV ganciclovir 5 milligram per kilogram twice daily for 2 to 3 weeks, and then once daily for 5 to 7 days for a week. Maintenance is done by oral ganciclovir, and then it can be discontinued once the CD4 is increased to more than 100 and sustained for 6 months following ART. So again, to repeat and to keep in mind that CMV retinitis is something which is not uncommon. It is very much there. It's just that because the fundus examination is not being done routinely. The next slide, please. So the oral valganciclovir is now the drug of choice for treatment of CMV retinitis, which is not vision threatening. And intravitreal ganciclovir or foscarnet injections plus oral valganciclovir is preferred initial therapy for patients with immediate sight-threatening lesions. So these are the drugs which is again according to the availability of the drugs, and also because you need a special hand because you need the ophthalmologist. So if you remember, if you go back to the initial slides that I was showing, so this is what I was talking about. If you get a set of symptoms like that, then you need to refer it to ophthalmologist, because if you get the confirmation of CMV retinitis, you know that the treatment is quite tough. So that's something to keep in mind. Next slide, please. Okay, so now I think we are covering the major or the common CNS or neurological manifestations. I'm sorry, I was rushing and I had to still rush because we are almost 1 hour over, and then we have only covered the CNS component. But then keep in mind whatever I said in terms of overall the approach when you look at the patients. What are the differential or what are the common differential diagnoses that comes to your mind? Keep in mind you can have a set of meningismus, you can have set of occupying lesions or the focal neurological deficits, and never miss the eye findings, because that's something which is very much missed in our settings. So with this, I think a neurological manifestation I'll conclude, and then I'll just take a quick 30 seconds break, and then we start HIV tuberculosis. Okay. Next slide, please, Shweta. Next, please. Okay, so let's talk about some of the basic introduction points for HIV tuberculosis. So, see, the overall incidence or the overall risk for PLHIV is it's almost 30 times more likely the patient can develop tuberculosis as compared to people without HIV. So that's what it is. So you know that PLHIV is definitely more chances are both in a year and the lifetime risk both are very much higher as compared to non-HIV patients. Then TB per se, tuberculosis per se, accelerates the disease progression of HIV, and AIDS per se can paves the way for clinical TB or mycobacteriemia. So it's a vicious cycle. It goes on. Then, and also we know it's HIV and TB. It's a fatal combination in terms of mortality. I mean, the mortality is quite high. Most still, TB is the major killer in co-infected patients. So. And management is quite tricky and tough. And at the same time, not just the management, even the diagnosis is quite tough in HIV/TB co-infection because of several reasons that we'll talk about. Next, please. So you see this in the slide. If you see, what we're talking about is the same vicious cycle that we just talked about. So TB per se. If you have an immune suppression in PLHIV, you know that the different immunomodulators or the immune cells which are there, which are not there, or the decreased amount of interferon gamma or the helper sites, ultimately that would lead to our progression of disease, or you get the clinical disease. And then once you have a clinical disease, then you know that there's going to be macrophage or cytokine production. You have interleukin-1 and tumor necrosis factor, and that would again help in viral replication, and that is going to give you AIDS. And then again, you get the immune suppression. So it's a vicious cycle. I mean, one or the other, you get the mycobacteriemia, and again, that helps in viral replication for AIDS and further reduces the immunity. So that goes on. The cycle goes on for HIV/TB. Next slide, please. In this slide, if you see on the left side, if you see, there's a clear increment of the lifetime risk of TB, which you can see in the HIV positive patient. So, the HIV negative and PPD positive 10%. If the lifetime risk is, you see the HIV positive and PPD positive, the lifetime risk is almost 60%, which is quite higher. So we know that the increased incidence of tuberculosis is due to the immunosuppression, and that too is more common in advanced HIV cases. Then also, one thing which is very important is that the primary infection that can progress into post-primary without actually having the primary infection getting arrested. So, that's the difference we'll also see in the subsequent slides. And also, reinfection with the new exogenous infection is another distinct possibility that we have seen in a lot of cases because of several reasons. And the relapse after stopping anti-TB treatment is also quite often observed, and that too more common in immunosuppressed individuals. Next slide, please. Next slide, please. Let's get into the technical discussion. Okay. Now, if you see this slide, you see that In HIV immunosuppression, you can have early phase and late phase, and then according to the features of tuberculosis, let's see how it presents in differently. Yeah. So typically in early phase, what you get is you get often which resembles the post-primary TB or the adult type. And then the upper lobe pulmonary TB or the cavity formation and the sputum smear positive pulmonary TB that are more frequently witnessed in patients those who are having high CD4 count. So you're talking about the early phase of immunosuppression. And then the late TB, which typically presents as or resembles the primary TB. The late phase, this is what we just talked about. So when the patient's having CD4 of less than 200, the clinical manifestation is usually the primary or the progressive primary. And in the absence of the typical immune defense, the cavity formation and the sputum smear positive TB are less frequently observed. So this is the typical presentation that you get in early versus late phase. We know that the sputum smear results are not going to be positive, often negative in the late phase of HIV. And also the chest X-ray, which you see often in the early phase, because that's the adult type or the primary type, you see the upper lobe and you mostly get the cavities. In the late phase, you get the atypical presentation, often with the infiltrates, and the involvement is of mid and lower lung field lesions as compared to early phase where you get the, or the post-primary TB type where you get the upper lobes involvement. And so this is how the difference is in terms of the phase of immunosuppression. Next slide, please. If you see the slide now, on the left side, which you see is, it's a typical relationship between the load, so the relation between immune system and mycobacteremia. So you see as the CD4 count is reducing, you see on the y-axis there is CD4 count, and as it is reducing, you see the mycobacteria load is increasing, which is quite obvious. And on the right side, if you see the extent of, so extrapulmonary TB, that it can involve various organ systems. It can from lymphatics to skin to liver to spleen to brain to bones, anywhere. So you see that as the CD4 count is reducing, you see that involvement from lymphatics to tuberculosis, meningitis to disseminated tuberculosis. It's quite obvious as the immunosuppression extends or the CD4 count reduces, you get more disseminated or severe forms of TB. Next, please. This is also important because now what we're talking about is we're talking about exogenous reinfection. So nosocomial transmission of TB has been reported to occur and is particularly frequent among immunosuppressed PLHIV. Now, this is something which probably we need to keep in mind, and also we need to have the alarm of, because everywhere globally, whatever we talk about, we always talk about the intensified case findings. We talk about the IPT or the TPT as we call it now, and the IPC or the infection prevention precautions that we have to take. But infection prevention is something which is, we all know that how important it is, but then how important is the focus from our side as clinicians. So this is what exactly is this talking about. So TB recurrence are due to the endogenous reactivation of the mycobacterium, which is persisting after treatment completion, and can have the exogenous reinfection or superinfection due to nosocomial spread. This is where it's quite alarming, and then we have to think about the infection prevention in a better way. Next slide, please. It's the same study which is talking about the exogenous reinfection. So there were, in the observational study, certain number of PLHIVs were followed, and the DNA fingerprinting was done, and then it was found that a lot of patients were having new strains of tuberculosis. So again, stressing upon the topic of what we just talked about, all other things are important. IPC is very important, but usually missed. Next slide, please. So for iris, so typically in a country like India, if you say what's the most common cause for for deaths, iris-related deaths, or anything, what are the most common OI which leads to iris? So, even when you're sleeping, you can talk about that. Yes, it's going to be tuberculosis, because the kind of prevalence or the kind of widespread tuberculosis, HIV, TB infection we have. Now, TB is the most common, that's the reason. So what we're seeing is TB is the most commonly recognized OI manifest as iris after initiating ART. So I'm not going to give a talk on what iris is, because we'll not be able to finish it now. But otherwise, I think in the last session, it was already covered what iris is. But then, you should read more about iris, hopefully. And it is, as known, it is associated with the restoration of the immune system, and then you present. So you can either present as a paradoxical form, or you can present as unmasking. You know that paradoxical is something which is there and then it worsens, and unmasking is which was not known, and then because of the immune reconstitution, now the patient is presenting with symptoms. And the most common symptoms that you come across is fever, lymphadenopathy, and intrathoracic lymphadenopathy. The mean onset of symptoms is 2 weeks, and mean duration of symptoms is 3 weeks. Next slide, please. So now, if you look at these X-ray pictures, it is of a HIV TB patient with who was initiated on first-line ART, and after on ART after 2 weeks of anti-TB treatment. And 4 weeks after initiating ART, the patient was presenting with fever, loss of appetite, and dyspnea. And you see the X-rays prior to ART and 4 weeks after starting the ART. So what we are seeing here is, or what we're talking about is, on the left side, you have a pretty normal chest X-ray. And on the right side, you see that there is increased of, or the blunting of cardiophrenic angles, which is typically talking about fluid collection. So this is a picture of, you have pericardial effusion, and it's not uncommon. It's not uncommon, TB pericardial infusion or pleural effusion because of virus, as a manifestation of virus, it's not very uncommon. So keep in mind. Next slide, please. Again, if you see chest of this patient taken prior to the initiation of ART, and then you see the X-ray subsequently 11 weeks after ART, you see on the left side pretty normal, other than typical emphysematous, a bit of picture of that. But otherwise, on the right side, you see that the typical cavitary lesions you have here, and then the sputum examination also showed it was pulmonary TB. Since it happened post ART, we would have to call it or name it as iris TB. Next slide, please. Okay, let's get into the some of the diagnostic modalities that we have. So you have a sputum smear examination, but I think what we are going to talk about is, we are going to more talk about in relation to HIV TB. I mean, otherwise for TB we can keep on talking, but I think in relation to HIV TB, we know that the bacillary load is quite low in immunosuppressed individuals, and that's why the sputum smear examination is not the very best investigation that you can do for HIV TB patients. Similarly, for X-ray chest, infrequent cavities, atypical manifestations are common. Sometimes you have the normal chest X-rays. So again, it's not the best in terms of diagnosis of TB in HIV co-infected cases. FNAC in immunosuppressed individual, again, findings might be negative. So you get a lot of false negative cases because the diagnostic yield is not that good. So that's something we have to keep in mind. Next slide, please. In this slide, you see that the sputum smear positivity during the early and the late stages of HIV, as you go on the right side. Now, in the early stages, the cavities are generally pulmonary, and the chances of sputum smear positivity is quite high, as it is known. And similarly, as the immunosuppression increases, and in the advanced HIV cases, the cavitary forms or the pulmonary TB, it's quite it's not that frequent. So that's why the positivity decreases of sputum smear positivity, what we talk about. Next slide, please. So let's discuss the some of the radiological features that you see in relation to the CD4 counts. And also, before I comment on that, see what we know is typically, if you talk about the general population, what the pulmonary and the extrapulmonary TB, the difference is almost, or the division is almost like 80 to 20%, right? So 70 to 80% are pulmonary and the rest are extrapulmonary. When it comes to HIV TB cases, this ratio is almost like 60-40. There are several systematic reviews that have been done, and still, I mean, some of the systematic reviews that are going on to comment on that. But then what we know is around 40% extrapulmonary. So you can imagine extrapulmonary TB and then the role of chest X-ray in diagnosis of HIV TB cases, and that too more in advancing immunosuppression. So on the left side, if you see, it represents the early stage. CD4 count is 362. A typical post-primary pulmonary TB showing a cavity in the right upper lobe, you see here. And then the central X-ray, if you see, the CD4 counts of 158. It typically shows the exudative pulmonary lesions with signs of progression into mediastinum, and the widened mediastinum is mostly because of the lymph nodes. And on the right side, if you see, again, the CD4 count is 31. X-ray typically shows bilateral disease with dissemination to pleura. There are, you can see the right pleural effusion, and then multiple the problem, the multiple features that multiple radiological manifestations that you get in the chest X-ray, it typically points towards the advanced disease. That's something which probably we'll have to keep in mind. Next slide, please. Now, when we talk about the relevance of X-ray, see, there are several studies that have been done, and then all these studies that showed, if you see the things which are highlighted in red here, the sensitivity of 72% and 57% sensitivity and specificity of chest X-ray. But all these studies have also shown that the sensitivity typically, once we did the sub-category analysis, what we noticed is definitely X-ray with somebody with symptoms of more than a cough of more than 2 weeks, or had more sensitivity. So what typically it shows is that definitely if X-ray can be associated with symptoms or the other positive findings, if luckily if you have the sputum smear positivity or the basal eye, you can find that definitely the sensitivity would increase. But otherwise, typically you have the sensitivity and specificity of 72%, 57% in the HIV TB co-infected cases. Next slide, please. What is important is, so we know that in the HIV immunosuppression stage, which is advanced HIV or late presenters, we have a low, and not just the late presenters, overall in HIV TB cases, we know that there is low sensitivity of sputum microscopy. And also because we know that there are less organisms, the bacillary load is quite low in the sputum. So, and then you do not, the cultures, I mean, it takes a lot of time. It is not possible to have cultures in all the facilities. The turnaround time, it takes weeks for us to give the results. So CBNet is something which was a game changer. I mean, to say that. Next slide, please. It's quite sensitive and specific. It increases the case detection because it's like, gives you result quickly. It's easy to do, improves the quality of rapid diagnosis, early diagnosis, and reduce time taken to treatment initiation. It can tell you the rifampicin resistance also. And yeah, it's feasible, not much of biosafety requirements. Next, please. If combined with the smear positivity, so this was the study which was done, and it was noticed and seen that, if you see here, smear positivity, this is the percentage, and with gene expert almost double everywhere. So the additional gain in case detection was huge, almost twofold in all groups of PLHIV. So something which is really good for us. Next, please. The smear microscopy, the median sensitivity is around 50%, as compared to sensitivity of CVNet. CVNet, which you saw here, we're showing the sensitivity of 84%. You can see huge gain. It is varied. It is varied in terms of the type of patients you're dealing with. So it is overall, the sensitivity is 84, which you see here, but then as there is immunosuppression or there are advanced cases, this further reduces. It is not 84% there. That we'll discuss in our subsequent slides. So overall sensitivity, if you remember, the range is quite huge, and that is because the subset of patients, or the kind of patients that you receive, whether they are having symptoms or what kind of a CD4 level they are in. So that depends on. So as you go further towards CD4 of less than 50, the sensitivity further reduces of CVNet as well. Next slide, please. The slide which you see here is talking about the CVNet for other specimens. So you can conduct for lymph node biopsy. So you see the sensitivity is quite high, 93%. For CSF it is 85. Pleural fluid is quite low. Then gastric aspirates, it's 78. Other fluid samples also 67, including the stool samples. Specificity is quite higher. So if specificity is there, but then it's very, so what it tells you is that you have got, so somewhere where you have high sensitivity and high specificity, it's very easy to perform it as a public health mode. But then somewhere where you have a very less sensitivity, it becomes difficult to apply this as a screening test. And that's why you need to combine it to improve the predictive value. You need to combine it with other things, for example, like 4S positive, and then going for CVNet. Next slide, please. This is a typical diagnostic approach that you have for TB and PLHIV. So any HIV infected patients, you do the intensified case finding. We look for 4S. Excuse me. We look for 4S screening. Just 1 second. Shweta, we have 10 minutes left. I'll try to be a little quick, but I still have 25 slides remaining.
Okay. We can go ahead after 5 also, no issues.
It's quite a big topic.
Yeah.
Okay, so you see that with 4S symptoms screening, you can divide it into pulmonary TB suspect or extrapulmonary TB suspect, right? So when you have a pulmonary TB suspect, then you know that you have a sputum CBNet or X-ray chest, and then you get the sputum CBNet positivity. That means it's confirmed that it's a microbiologically confirmed TB. So this algorithm is just to name, how you're going to tell that this patient is microbiologically or clinically diagnosed TB. So when you have a sputum CVNet negative and X-ray is suggestive of TB, then you know that you're talking about clinically diagnosed TB. And then you have sputum CVNet and X-ray negative for TB. Then you have to think about other specimens or the follow-up of patients is important. Then extrapulmonary TB suspect, where you have, if it is possible, CVNet can be done for other extrapulmonary sites, as we discussed before. And if that is positive, then you know that microbiologically confirmed TB can be assigned. Then again, depending on the site or where the patient is having the issues, if you have lymph nodes, etc., you can do FNAC. Again, look for whether you can actually look at the organism. If that's there, then you know that it's microbiologically confirmed TB. Otherwise, you look for X-ray or ultrasound, abdomen, etc., and then you look for. And then along with that, if it's CB negative, then you know you're talking about the clinical diagnostic. Now, something which I touched upon before. So you see all these algorithms, you can always see. I mean, we can have a days-long discussions on this, but something to keep in mind that extrapulmonary TB, the percentage is high in HIV TB co-infections. As I told you, around like 30 to 40% cases would have extrapulmonary. So you need to be a little mindful when you see the cases. I mean, if somebody is not having these typical pulmonary symptoms, but then you look for other symptoms and try to see, because in HIV TB, this is a big problem. Diagnosis, it's quite tricky. Huh? Next slide, please. And then this is a bit on the typical approach that you have for drug-resistant tuberculosis. So any presumptive case that you have. So I'm not going to go into the details of each and everything, but what is important is, next slide, please, show that. There are a few highlights. One more. So, I mean, we talked about that CBNet can pick rifampicin resistance, right? So if you have rifampicin resistance, but then what you don't know is whether the patient is also having H resistance. So rifampicin is there, but then you don't know whether isoniazid is also resistant. So if it is resistant anyway, you have to refer the case, and there are typical PMDD guidelines on how do you manage these cases. I'm not going to go into the details of that. It's not possible here. And then if it is R sensitive, then also you send the sample for first line, because, as I mentioned before, it only picks the rifampicin resistance. Next slide, please. Now, for just for some time, I would like to spend some time on this. I know it is a new test. I'm not sure how many people in the group have heard about this. So this is a urinary lipoarabinomannan assay test. What it does is, so you need to, one is it's quite exciting time, because you can check the tuberculosis by your urine sample. It's perfectly non-invasive test. Huh? It's almost like, what do you say? It's almost like kind of a rapid test which you use for pregnancy. So, how does it help? There are right now, there was a company called Alere Company which produced this, and we do not have typical Indian specific data. So, that's something which we are struggling with, and this test is currently not registered in India. But it has got a definite advantage in typically the patients with CD4 less than 100. So what is, the LAM is approved to be used in India. So what it means, Bhavna, what I'm trying to say is, not approved. So LAM is not approved to use in India. That's exactly what I'm trying to say. So LAM is a WHO recommended test, but because we do not have any registered manufacturer or approval from DCGI, that's the reason we still are not able to use it in India. The current guidance, the TRG has recommended again for advanced HIV cases, and we all are working on it so that we can bring this. I mean, this is quite useful for advanced HIV cases. So let's see how does that take. So for information, again, because this is a theoretical class, this test is recommended by WHO and the TRG, but it's not approved for use as of now. But for the theoretical aspect, how does it help? So you see the difference that I've given in the typical slide. What you see here, the advanced HIV cases, if the CD4 count is less than 100, the pooled sensitivity is around 49%, and the specificity is 90%. The CD4 count of less than 200, the pooled sensitivity of 56% and 90%. One should raise a query here that why we are talking about something which is only 50% of sensitivity, wherein you see that the CD4, the sensitivity of CBNet is almost 84%. But the overall sensitivity of CBNet, what we have seen around 80%, it's in the overall cohort. And this is a specific advantage of LAM in this cohort of advanced cases where the CD4 is less than 100, the sensitivity increases. It's better than CBNet. So the topic here is, one can read about it later, because there is something called sequential and there is something called simultaneous screening. So when you do the sequential screening, that means one by one, or simultaneous when you do at the same time. So for example, if you have 4S symptom screening, and then you have CBNet, and then you have something like TB, LF-LAM, probably the overall sensitivity is going to increase a lot. So that's the basic concept. So for the concept's sake, I'm telling you this. I'm not saying that you from tomorrow onwards you should start asking for LAM, because it would come through a proper channel, and NACO would give the approval for that. Next slide, please. So now let's talk about type of TB patients. So there are going to be some slides that I'm going to quickly skip now on, because these are going to be little basic things for all of us, and because we do not have much of time, we still have 30 slides to go. So new patients, by definition, we know that who had never had treatment for TB or has taken a TB drug for less than a month is considered as a new case. Previously treated a TB patient who's received 1 month or more of anti-TB drugs in the past is considered as previously treated case. Next, please. So we talked about these classifications when we were talking about the algorithm. But anyway, you'll be having the slides and you can go through the definitions, and this is quite self-explanatory. Next slide, please. So this slide is talking about the drug-resistant tuberculosis. So there is also one more thought process of the concept, which I would like all of you can think about and read more. So right now, what we see is in India, around 3% of new cases are as drug-resistant cases, and around 16 to 17% of retreated or the acquired cases that we know of. So that's the typical prevalence or the burden that we have of drug-resistant tuberculosis. But does HIV, so this is a typical general population. In PLHIV, does the prevalence increase for drug-resistant tuberculosis? So let's think about it and think about it more. Theoretically, it has all the reasons because of the confounders, because of the similar risk factors, because of the malabsorptions or the different pathophysiologies that we know. So theoretically, yes, it's a possibility, but there had not been much of the systematic reviews or the studies that can actually talk about this. There had been some had equivocal results, some had towards in favor of that, yes, HIV population should have more of drug resistance. But as of now, it remains equivocal, and there are systematic reviews going on, and hopefully in coming 1 year, we will have more information on that. So theoretically, yes, it is a possibility, but we do not have enough of data to comment on that. Next slide, please. So what we know is, so what we're seeing here is MDR and XDR TB. So MDR, a patient who is whose sputum is cultured positive for TB and resistance for isoniazid and rifampicin. That's typically called as MDR, and XDR TB is when you have also further resistance to at least to fluoroquinolones and a second line injectables. Further in coming times, we'll see the changing definitions of MDR plus pre-XDR or so right now what we have is MDR, pre-XDR, and XDR. XDR is when you have a rifampicin and isoniazid plus fluoroquinolones and second line injectables. Similarly, pre-XDR would be any of these two, FQs or second line injectables. But then recently now the discussion or the nomenclature is changing from MDR plus minus the extra resistance of drugs. But then that's not the scope of today's session. There's something which I would say that please read more about it. Next slide, please. Now, the 3 I's, or the reduction of burden among PLHIVs that we also talked about previously before. So we know that we have greatly talked about the intensified case findings. We have talked about the bit of the algorithm that we'll be discussing more now, and also the airborne infection control measures. This is exactly what I was talking about when we talked about the reintroduction or the exogenous new strains that the patients get. So please keep in mind that IPC is a very important phenomenon. And then we'll talk about the TPT, or the preventive therapy. So now IPT is being changed to TPT. We'll see that. Next slide, please. Next slide, please. So let's talk about the importance of fluorescence screening. You see in the slide, clearly is telling you, you see the combination rules. So when we are seeing is the symptoms, the syndromes that you have with cough, fever, hepatitis, night sweat, or weight loss. So whenever the patient is presenting with these symptoms, we know the sensitivity is high, specificity is low, but the negative predictive value is quite high, 98.5. What does it mean? It means that if any patient is not having these symptoms, the patient is unlikely to have TB. So that's what the negative predictive value is. So definitely the symptoms would definitely help. Next slide, please. The 4 symptoms complex among PLHIV is a little different for adult children. I am 100% sure that all of us know about it, but then I'm going to quickly go through these now because of not much of time we have. So adult, we have current cough, fever, weight loss, and night sweats. Children, current cough, fever, poor weight gain, and contact with TB case. Next slide, please. Now you have, so you know, when you do the case finding, you have the set of symptoms that you have to look for. You see if the symptoms are there, they investigate for TB. If you find a TB, they treat it. If you do not find TB or the active disease is not there, you treat or you start the IPT. Then similarly, if 4S or nothing is there, then you know that then you assess for contraindication to IPT, and accordingly you manage. If the contraindication is not there, you start on IPT. Otherwise, you defer IPT. Next slide, please. Next slide, please. I think it's the repetition of saying. Yeah. So HIV and tuberculosis management. I think we all know about these, the difference of new and previously treated cases and the treatment regimens. I hope, I'm sorry that some of the slides probably I might skip. So next slide, you see that we are seeing, next slide please. The FDC combinations that we have for intensive phase and the continuation phase. Next slide please. In the overall treatment regimen, based on the clinical decision, the continuation phase can be extended, typically seen in the CNS TB, skeletal TB, and disseminated TB. That's something we have to keep in mind. Next slide, please. So in the next slides, what you're seeing is the dosing schedules, or according to the weight band. I think no need to discuss that here because you will be having the slides and you all can see that. Let's move on to the next slide, please, Shweta. Let's go to the IPT, slide number 90. Because these interactions in the next sessions on drugs, etc., I can cover there, so we don't need to worry about those things. No. Go to 91. Go the previous one, please. Previous. Yeah. Okay. So what is important is we all know the preventive therapy that we're talking about. So right now, again, I would recommend that please all of you should read the recent guidance on latent TB management or the prevention. We have got a lot of options as of now, but then right now, because in India we're still dealing with isoniazid, so we'll talk about that. But then there are several 3 months, 4 months, or even 1 month therapies which are there, and it's shown to be equally proven and you would definitely say that the adherence would be better in that. So let's come back to what we have in India, but then please read those WHO recommendations for LTBI, latent TB management. Also, at the same time, just because we do not have any comment on the TST, the skin test, or the IGRA, the test that we recommend or talk about to rule out diseases before you start on the management for latent TB. But then as of now, as a concept in India, we do not have those things. So, just to let you know that those things you should read from that document. Okay, so when you do the screening for adults and children, accordingly, then you screen. If the symptoms are not there, that most probably, as if you remember, we talked about the negative predictive value of the set of symptoms. So you're sure or almost sure that the active disease is not there, but it's still a problem in HIV TB. We'll come to that later. Then you send to ART-MO for IPT assessment, and based on the eligibility, you start the IPT. Similarly, for children also, you follow the same thing, and the different line list and the different background work that has to be done, and then IPT should be started. Next slide, please. Some of the contraindications to IPT, well, it's more of a common sense, right? So if you have active tuberculosis disease, you should not start. And then for the concomitant reactions or the toxicities, if active hepatitis is there, you should not start. If there are signs and symptoms of peripheral neuropathy, you should not give, because that isoniazid leads to peripheral neuropathy. Poor adherence to CPT, poor understanding. These are mostly relative things, but then still keep in mind. Poor understanding of IPT by guardian, context of MDR TB, and PLHIV who have completed DRTB treatment are not eligible for IPT. Next, please. You see in this slide, what we're talking about is in the different studies where the reduction of TB risk is seen, it's clearly evident that ART along with the IPT has got a clear benefit. So in all the studies done, you see the significant impact when the ART has been combined with IPT to reduce the TB risk, be it Brazil or South Africa or Botswana and South Africa. So similar context, but then 80%, 89%, 97%. So quite significant impact when you combine both. Next slide, please. Concomitant use of IPT is recommended. Duration of effectiveness of IPT in absence of ART is limited because of ongoing progressive immunodeficiency. And when we combine both, there is likelihood of restoration of specific immunity by ART, and then definitely the beneficial effect of IPT might be prolonged. Next, please. One should not worry about the resistance in IPT when used to treat latent TB infection. And in latent TB, the tubercular bacilli are very few in number and dividing slowly, and therefore the risk of selecting the typical mutant or the drug-resistant mutant is extremely low. It has been clearly shown in the studies, and also there was a study done which reflected the prevalence of INH resistance among IPT exposed, which was similar to the background population. So it clearly shows that the resistance issue is not that evident. Next, please. The regimen that we know for adult and adolescents, we know isoniazid 300 milligram plus you have to add pyridoxine for 6 months, and similarly for children above 12 months, you give isoniazid 10 milligram per kilogram plus you add pyridoxine, and that's for 6 months. Next slide, please. So this is the dosing chart, and I think we can avoid. Next slide, please. Okay. So this is important. So what do we do when so we're talking about the Indian scenario now, where TB is so common that if IPT is to be used, we know that a rational approach is to start IPT after completion of about 3 months. So this is called delayed IPT. This is an Indian specific thing, and probably more makes sense because the chances of the iris or the prevalence of the subclinical tuberculosis that you have, and the risk of neuropathy or the other interactions that you can have So all these overall for the overall clinical response, I think it's important to follow this. Next, please. So this is the almost last slide. So this is what I was talking about. So when you see TPT beyond isoniazid now, globally, WHO has also recommended that. So you have got different, according to the incidence settings, there has been recommendations for even for 3 months or less than 3 months. So this is something to keep in mind. The guidance is there, but I'm not going to talk about more on this because currently what we're using is isoniazid. So that's mostly my last slide. Next slide, please. I think that's the end of it. So what is important, I think, sorry for, because the topic was quite huge, and sorry for rushing, but I think what my intent was, in the overall presentation, I've given some of the hints and some of the topics that probably you'll have to still read. Do not expect in 1 or 1.5 hours you can cover HIV TB or the CNS complications or the manifestation. So please read more on all the things that I prompted, and hopefully it was useful. And yes, Shweta, it's open for questions.
Thank you, sir. Participants can now unmute themselves if they have any questions. So I don't think there are any questions. Please feel free to write your questions on the WhatsApp group also.
Sure, and then in case if there are any documents or anything you might see that you're not able to find, or you think that you need assistance in that, please reach out. I mean, I can help you with the different documents that you need, whatever I prompted in between. So yeah, happy reading, and please be safe. Enjoy. Hopefully this phase shall pass. Take care.
Thank you, sir. Thank you to everyone for joining. We'll end the session now. Stay safe.